into perinatal and parent-infant mental health. And as part of that, we started to think some years ago about health inequalities across Greater Manchester and what we could do to try to understand that a bit more. So I was kind of tasked with leading on a piece of work. There was a one-off small pot of money. So as part of that, I had some conversations with various people in Greater Manchester, but came across the work that Faye had done on the maternity experience of Black women in Greater Manchester. So it seemed like an ideal opportunity to look at building on that work, to look at that broader perinatal experience, in particular thinking about well-being and mental health in that perinatal period. So that's how the work came about. We're really excited to finally launch the report. It is just the start of exploring health inequalities in Greater Manchester. We know that there's still a lot to do when considering that perinatal and parent-infant mental health experience. But this is a great starting point, so I hope you all get a lot out of the session today. Thank you.
Thank you very much, Sarah, for that overview. So colleagues, welcome to those who have just joined. You can use the chat box throughout the event, and also we're going to record this just for some who couldn't make it. So at this point, I'm going to hand over to the chair for the Caribbean African Health Network, but also the report author, who is going to walk us through the report, and then also bring in some lived experience. Over to you, Dr. Faye Ruddock.
Okay, thank you, Charles, and good afternoon, everybody, and thank you for taking time out of your Friday afternoon to hear about the findings from this report that we did and completed last year. So just to mention as well, we've got a Mentimeter in the chat box. I believe it's in there. So if you've got any particular questions, we've got some questions in there that we'd love you to be able to give us a response to, because at the end of this, what we always like to do as CAHN is to do a bit of a follow-up, so we can give you some insights into what happened during this event, but also, to tell you about the next steps as well. So we do want to do that and answer any questions that we aren't able to answer during this short session. So thank you once again. So I'm just going to go through some of the findings from this report, and as Sarah has mentioned, this is a really important piece of work for CAHN. I mean, CAHN, for those that don't know, the Caribbean and African Health Network, we set up in 2017. And one of the things that we got from a piece of work that was being done is about how many Black women had a very poor experience during their maternal journey. And so doing some of the work that we did, which was called the Black Maternity Advisory Group, Black Asian Maternity Advisory Group, which I co-chaired with an obstetrician at MFT. There were so many gaps and so many experiences, and one of the things that was really pertinent was around people's mental health. So when Sarah approached and asked about where some of the gaps were, mental health was a real issue, and you'll see from some of the data that I'll share in a minute why it was really something that we wanted to explore even further. So I'm going to take you through these slides, and I'm going to bring in two of my lived experience people that will share with you what it's been like for them in Greater Manchester. So if you can just go to the next slide for me, please. Can you go to the next slide? Okay, so this report, as I said, was commissioned by Home Start, and we identified this work, as I said before, from BAMAG, and it really delivers on some of those real life experiences. And not only the real life experiences, we also drew on some kind of survey consultations with our perinatal and infant mental health teams across Greater Manchester. So we asked a number of questions about, their services, and we got some feedback, and we've got some key themes that came from that. And also this report does make some recommendations, and I'll talk to you a little bit about those as well. So if you go on to the next slide for me, please. Okay, if you just go to the one before, yeah, that's it. So in terms of the context, you know, I'm sure many of us know we've got some very unhappy faces on here, because we know that 1 in 5 Black women are less likely to visit a health professional, and for some of the same reasons that we have right across our health system. You know, there is a lack of trust. There are, you know, some challenges in terms of access as well, and some of the cultural and religious reasons around that as well. But we're less likely to visit a healthcare professional. We're 13% more likely to experience postpartum depression than any other group. And also suicide as well accounts for 39% of deaths 6 weeks to 12 months after the birth. And of course, if you know anything about the Embrace report, you'll see that mental health is one of the main reasons why we have high rates of mortality. And then 37% of the women who died were known to have a previous or existing mental health condition. And I'm sure we'll probably hear it many times on this call about how Black women are, it says, just under 4% now, more likely to have a mortality during their pregnancy or shortly after. So we're more likely to have a mental health illness. We're more likely to have the underlying health conditions as well that aggravate our perinatal experience. We're more likely to be discriminated against, and that's right across the different determinants of health. We're less likely to get access to information as well. So if you think about migration, and we know in Greater Manchester, there's been a huge increase in terms of migration from places, particularly like West Africa. We're more likely to have limited health literacy and the inability to navigate the healthcare system. And also, which is really, really important, it's about our social networks and the links that we have to people that can help us to mobilise through some of the challenges that we often face. If you could just go on to the next slide for me. So this piece of work is really just about exploring those experiences of mental health for Black women throughout their perinatal journey. As I've said, we've consulted with the teams. We didn't just sit and talk to the women, although that was incredibly important. We wanted to hear the voices from the perinatal teams as well, or certainly the infant mental health teams, but also to explore those experiences and the impact on their mental health. And we did some focus groups, and we've got some recommendations that we will share. Okay, on the next slide, please. So again, the methodology, and just kind of to say on here without going through all the slides, is that we had a cohort of about 38 women that were part of the focus groups. And then we had some interviews as well that we did. And the age range of all of the women within 21 to 43 years of age. And, you know, we did this over a fairly short period of time, but you know, many people wanted to come forward and to share their experiences. Okay, on the next slide. And only on this slide, which you'll see in the report, you know, in terms of how it was all done, how we recruited, how we analysed the data, and also how we developed those recommendations. And to say that every recommendation, as it should, reflects what people were saying from the report. Next slide, please. So these were some of the highlights from the survey data. So this went out to all 10 perinatal and infant mental health teams, and particularly the parent and infant teams it went out to. But what I've done is I've collated a lot of data that came from BAMAG and also other conversations that we were having across the system. So what we can see here is that, you know, we've got 40% of those teams that did not have service user involvement in reviewing service information. There was the service leaflets were not available in different languages, largely. Also, one of the things that we talk about very often is how important it is to have cultural and religious information for our communities. I keep saying that in terms of the Black community, 84% of Black people will go to a church or have an affiliation to a church, and many of our Black Muslims will also, you know, visit a mosque. So it's really important to have those materials that reflect some of those religious beliefs and practices. We don't have education and training on racial, cultural and religious beliefs, and that came out through BAMAG as well, that we don't really have a kind of education and training that really tell people, providers, what we need, what they need to know to look after us better. Also about complaints, that all the teams, nobody had really had any complaints on Black women, but when we speak to those women, there are lots of things that people were not happy with. And also only a very small number of teams are actually working with VCSE organisations, and we know how important it is to work with the VCSE sector, because we are very close to the people, and we're often trusted people that will come to us to get kind of advocate for them. So it's really important that we have that, but there was very little of that happening. And also we talk about the religious and education, but also just generally, these were things that were missing. If you go on to the next slide, please. So in terms of the survey, coming from that data, we have limited visibility of racial, cultural and religious reflections in service materials, lack of education and training on race, low levels of involvement from our staff, minority staff, and service user involvement was virtually missing, and then the language barriers as well was not there. So these were the themes that came out. So on the next slide, please. And this is from the discussions that we had in terms of the focus groups and the interviews, these were the key things around fear and repercussions of highlighting concerns. And what I was going to do, but you'll see it in the report and it's in the chat box, is about how some of the quotes and some of the things that people were actually saying to support some of these themes. So the fear and repercussions of highlighting concerns, identity and expectations of Black women. And that's not just about the system itself, it's also about our cultural expectations, about giving birth and, having children, and some of the real pressures that we are ourselves under. Accessing health in safe spaces, people wanted somewhere safe to go to be able to get the advice that they needed, and they wanted some wraparound support. So accessing help was a real issue for many of the women. The religious and cultural biases and enablers, and some of the sharing needs with partners and spouses. And often we forget about, the male father, the father in all of this as well, or the partner, I should say. So how do we share those? And there's a real concern to some of the people on the focus groups. If you go on to the next slide, please. So rather than me going through the slides with all the quotes and things, I just wanted to bring in two of our service users, or people that shared their lived experiences that informed this report. So I'm going to bring in Treasure. Treasure's not going to be on camera, but she wants to share her experience for a few minutes, just about how it's been for her during her pregnancy, and then we'll bring in Samantha. Okay, if we can just have Treasure unmuted so she can speak. Thanks.
Hello, everyone. So I'm going to be talking about my experience during my second pregnancy. So during the early stage of my second pregnancy, I had a midwife, but I observed that she was much more concerned about baby than my own welfare. She always asks about how baby is faring, if I'm happy with the baby movements and everything about baby, and so despite the fact that I was going through difficult time at that moment, and which I told her, I explained everything, being separated from my ex-partner due to domestic violence, and him taking away my little girl, not allowing any form of contact and all that, and accusing me of physical assault on him and my little girl. So all these were kind of, very difficult for me, and coupled with pregnancy made it more difficult to handle at that time. But she wasn't really more concerned about how to, help me through these difficult situations. So maybe because I wasn't really looking like what I was going through at that time, So many times I broke down in tears in my flat. And on one occasion, I can remember I slumped in my bathroom, and and all that. I had no family in the UK except few of my friends who live a bit far from where I was staying at that time. They offered me their support and help, and also helped me explore through different options on how to go about my challenges and difficulties. So fast forward to the period I had my baby, I took myself to the hospital after my water broke just about 2 a.m. on that fateful day. Yeah. So it happened that I was admitted in the hospital, and I was told that I will be getting induced if I didn't go into active labor within 24 hours. But before then, I was booked for induction. My water broke 3 days before the day I was booked for an induction. So I was there for more than 45 hours. Nothing happened, and the midwives, they were not even checking on the baby like frequently, because I was sure that the baby was at risk of asphyxia and anything could have happened. What happened?
Sorry, Treasure, please could you just unmute yourself again? There must have been a little glitch there. Hi, Treasure.
Hello?
Treasure was lost. Yes, you're back. Thank you.
Yeah, oh, sorry about that. So, like I was saying, I knew my baby was at risk of asphyxia, and but they were not monitoring my baby frequently as it should be. So I was very worried, and I had to talk to a friend of mine who was constantly checking up on me while I was in labor, and she referred me to CAHN. And surprisingly, within 2 to 3 hours of CAHN intervention, I was taken to the labor ward for induction. So throughout my period of pregnancy, there was no self-centered care. I was just being cared for like every other regular pregnant woman, despite what I was going through. I was going through a very difficult period at that time. And there were a lot of things that happened, but because of time, I would just say that I could have had a better experience if there were other kind of measures in place to, look after pregnant women or Black people that are, going through similar situations. So that's a little bit of my experience.
Thank you so much, Treasure, for sharing that. And I'm sure, many people, and we know many people shared very similar experiences that we spoke to, but thank you for sharing. I'm going to go to Samantha now to share her experience. Thank you, Samantha.
Hello, thank you very much. My name's Samantha Bansu, and I'm not only a professional, I'm also the chair of the CIPD in Manchester, and I'm also a mother of 6 children, all under the age of 7. My youngest being in front of me now, 10 months old, and my oldest being 7. Now, for me, I have had quite a few pregnancies, as I've just mentioned, and what really saddens me is my experiences in all of them, apart from the one where there was a woman of colour who was a nurse who was there to help me give birth. And that's quite shocking in itself. I've had myself experience life-changing injuries as a result of negligence, as well as my latest child, my last child, almost have a near fatal sorry, it's going to be quite emotional, this, where near fatal instances with jaundice where she was about to be discharged, and if I didn't ask, she wouldn't be here to double check. and she was in intensive care for 10 days. And it's basically due to little things like looking at her colour, making sure, and because she's a little bit darker, they didn't pay any attention. Now, throughout my experiences, I've also had 3 miscarriages. And when I track back all the things I've gone through in motherhood and getting to motherhood, I have found that I have lacked support. It has, really impacted my mental health. I have been told that I probably have birth trauma and post-traumatic stress disorder as a result of what I've gone through. Yet still, as I stand here, or sit here, I've still not had anyone or any health professional said, here's counselling, here's support, despite these conversations. During my 5 pregnancies, I've mentioned that I've faced very avoidable challenges that have led to life-threatening challenges, including sepsis for myself. There's been a time where I was told that I didn't look pale enough, therefore I wasn't given the necessary support, and I collapsed after and nearly obviously died. My kidneys were failing, my liver was failing, and I wasn't given the appropriate support at that point. So you can understand why I would feel the way I'm feeling, and I'm trying at this point not to cry, because this is the first time I'm really sharing how I actually am feeling as a result. Now, in light again of these challenges, I really believe if there was some comprehensive support sort of hub or significant specifically for Black women, because one of the things that I understand is when we have representation, when we can see people that look like us and understand our culture, barriers and nuances, that can really help to advocate in the spaces that we're in. And recognizing that we also have unique challenges. We are built different, we have different backgrounds, as Faye has already rightly mentioned. That means that we, present different. And from my my very short I can't because we've only got a short time. I really just kind of want to urge that there's a collective stand and advocacy for this increased awareness, funding, because one of the things that I did is I tried to look online for support, and when I went to go finally find counselling, they said, I'm so sorry, the funding's run out. So that was quite really sad for me, because then then that's it, then I'll do nothing about it, which means that I've had a need unmet basically by the services that are there to support me. In addition to that, I've also had family members who have gone through shocking situations, including one of my cousins, one of my family members, who unfortunately miscarried, and instead of them looking after her, they put the baby in the bin, as in her miscarried child into the bin, and she hasn't had her own counselling or experienced her own counselling, and we're constantly hearing the same stories, people being neglected and left because of what is neglect really by the system. So in addressing this, I really think that the healthcare system can have some sort of ongoing support for women of colour and a hub, so that we can actually really get over these struggles that we've gone through, to share our stories, but also to have that necessary kind of mental health support that we need, that I need, as I stand here, I know that I need this. So yeah, I'm happy to answer any questions. I'm sorry about the background noise there. I'm happy to answer any questions and share more about my experience, but I will stop and pause there just because of the time.
Samantha, thank you so much. And, just for sharing just such information, just experiences. And I'm sure we all feel, what we feel because of what you've been through, and we all passionately want things to change. The same with Treasure's experience and the many experiences. Some of them are incredibly heartbreaking, what we hear about what women go through. So thank you so much for sharing that your experiences, Samantha. I'm just going to carry on and just talk about, what next, so in terms of what we heard and some of what we have recommended now, what we want to do is we want to have, because the things that we found out were not there in some of our services is to look at how we can develop some of these resources and develop them so that they are helpful for providers, but also for service users as well. So we wanted to develop those, and also the training and education that we know is not there. This is right across perinatal and infant mental health services. We want to be able to look at how we can develop those. If we just go on to the next slide or further down, I think, yes. And looking at service design, we want to be involved in some of that service design as well. We want to be able to use some people that look like us, you know, to be able to redesign some of these services so that they're fit for purpose. And also the data collection. And I've just been on a call which is with talking about, it was a Labour Equality, the launch of the Equality Act if they become in government, talking about the importance of data collection, so we can target you know, where the needs are a lot better, because we don't do that very well, and that's something that we've all picked up on during this whole exploration. We don't do data collection very well, so how do we know what the needs of people are? If you go on to the next slide, please. If you can just make that a little bit smaller, because I can't really see it. But we have some calls to actions. They're all in the report as well. And we want the system to listen to us. We want them to respond to us. And we want to be having these, you know, what these recommendations are. We want them to be built into the 5-year plan. We want to be part and parcel of that plan. So those are some of the calls to actions that we've got. And I think that's the end of my presentation. And I think I've just run over, but Charles, it's back over to you. Thank you.
Yeah, thanks, Faye, and thanks to Treasure and Samantha for sharing your experiences and lots of positive feedback in the chat as well. I think at this point in time, I'm going to hand over to Dr. Sarah Jones, who is consultant perinatal psychiatric lead, you know, and also based at Greater Manchester Mental Health Trust, for her to take us through some of their services as well as what they're doing to respond to some of those challenges and solutions to provide equitable access. Dr. Sarah Jones, over to you.
Thanks so much, Charles. Thank you for that. And thank you to Treasure and Samantha for sharing those stories. It's incredibly brave of you and really quite shocking, but it is amazing to see so many people here today to discuss the possible solutions as we move forward, hopefully as a tighter and stronger group. Thanks to Faye and Charles for bringing us all together. So I've got a very short amount of time and quite a lot to say, so I'll get started. But I'm Sarah Jones. I'm a consultant perinatal psychiatrist on the Mother and Baby Unit in Manchester and the lead for GM for perinatal services. And I'm presenting today on behalf of myself and Pauline Lee, who I think it was Pauline's service who contributed to the CAHN report, the Parent Infant Service. But we know, as we'll see as we move through my slides, that the themes are applicable to parent, infant and perinatal services at a national, regional and local level. Next slide, please. Next slide, please. So I just want to outline the services that are available. We have a Mother and Baby Unit, which is based at Wythenshawe Hospital in South Manchester. This is a 10-bedded unit that admits women with severe mental health problems in the perinatal period from 32 weeks of pregnancy to a year postnatal. The Mother and Baby Unit has been in Manchester for many, many decades, about 30 to 40 years. But it's the specialist perinatal community teams that most people will have, will come into contact with if they've got a moderate or severe mental health need. And our specialist community perinatal teams have been established since 2018 and cover each of the 10 boroughs in GM. And more recently, in 2022, we launched our PETAL service, which is our trauma and loss service, which is related to trauma and loss due to the maternity experience. In terms of, next slide please, in terms of the parent infant services that we have in Greater Manchester, it's widely recognised that Next slide, please. Thanks. That healthy first relationships are vitally important to a baby's functioning, and we've been very fortunate in GM to have parent-infant services and a lot of expertise and experience, particularly from the Tameside and Glossop model, which is led by Pauline, who, like I said, is the lead for parent-infant services in GM. We recognise that perinatal services and parent-infant services need to work together to ensure that the early foundations are built for allowing the best foundations for babies' brains, psychological, social, emotional and physical development to happen. There are many reasons why mental health and parent-infant relationships can be difficult, and we have perinatal and parent-infant services to support all of the women and families in GM. Next slide, please. So we have 10 parent-infant services across all of the boroughs, 3 community teams in perinatal that cover the 10 boroughs, and a mother and baby unit and a petal service as well. The parent-infant teams are slightly different in that they work with families from pregnancy up to 2 years in most of the areas, but some of them offer an extended service up until the age of 5 years as well. Next slide, please. We recognise that we can't be working in silos, and that perinatal and parent-infant has got a huge number of interfaces, and so what we are committed with the perinatal and parent-infant leads group, which so we're lucky to have Sarah Cook as the lead for the voluntary sector on, is working towards realising our ambition of a whole system approach, where the ambition is that families can seamlessly weave through services as and when they need them, and that those services have got such good and close relationships that they don't have to repeatedly tell their story, or that there's not barriers to accessing the right services that they might need at the right time. Next slide, please. So we really welcome this report, and we are, shocked. Obviously, it's incredibly hard reading, but it's incredibly important, and we recognise that this is a major problem that needs resource, a strategic response, because it's not just the CAHN report that's highlighted the inequality and inequity in perinatal services and maternity services across ethnicities. We also know that the Embrace report has highlighted these concerns, particularly in the maternity setting. We know that Black women are 7 times more likely to die than white women, and we know that there's been some projects trying to establish breaking down institutional racism, the 5 times more project as well. So we've known for some time that this is a major problem, and really welcome the findings of CAHN and this report to really bring it home to us at a local level, and particularly in our own services. Next slide, please. Sorry, I was meant to go on to this slide, but yeah, we welcome the findings. We want to understand and hope that we have that the framework has been developed for potential spin-offs for other cultural groups and identities as well. It's been really helpful to see how the project has laid out all of the challenges, and I think now what we need to really respond to is the call to action as set out in the report, and think about a strategic and well-resourced response across the systems, not just at a service level but at a GM ICB system, and hopefully that's what we're all here to do today. Next slide, please. It reminded me when I was reading this report of a statement that a Black trainee of mine on the mother and baby unit said to me in the middle of a ward round, which was really quite a powerful message. We were talking about a family, a Black woman who had English as her second language. She had 5 children, and she had been at home and she had been burning coals at home, which social services got very concerned about her burning coals and the risk that potentially that posed to her children at home. And she ended up being admitted to the mother and baby unit, and the trainee on the ward was familiar with burning coals and the practice behind that. And she got very cross, understandably, and very frustrated, and she felt that a disservice had been done. And there was a real lack of understanding, a lack of cultural competence, and a lack of curiosity as to why this was happening. And she stood up and she stormed around the room and she said, my goodness, with a few more expletives than that, but my goodness, if we aren't drinking tea and eating crumpets at 5 p.m, you all think there is a problem. And I think it was just really brought it home to us all how culturally incompetent we can be, and how helpful it is to have people from a very diverse number of different backgrounds to help shape our thinking about, you know, what might be happening here, what the normal cultural practices are, and particularly when we know that a lot do relate to the maternity experience as well. So I just wanted to share that with you, because I always think about it when I think about presentations from different countries and different ethnic groups. Next slide, please. So what are the challenges? Well, the challenges have been laid out in the CAHN report: limited visibility of racial, cultural and religious reflections, lack of education and training, low levels of involvement of minority staff and service user involvement in proper, meaningful co-production, language barriers, inadequate interpretation of service materials. And we also know that that's not peculiar, those findings aren't peculiar to the CAHN report. There's a paper that was published by our perinatal colleagues in Birmingham, and what they found were the same kinds of themes. There was a difference in access of the women who were accessing the perinatal mental health service in Birmingham compared to the population of that was being served by that service. And so we know that there was an issue there, and it was the same themes throughout the qualitative research that came out: limited visibility, lack of education, poor co-production, lack of meaningful engagement with faith leaders, communities, and all of these themes come up then, and have also come up in the East London project. This is a new project that's been launched and being run by colleagues, which is funded by the NIHR, excuse me, and this is the East London Equity Board, and they've been presenting in some national forums over the last 12 months and looking at how we can really ensure that there is coordinated and strategic responses. And yes, they are funded, and I think it's very important to think about the lack of funding and resources at every level and how that is a major obstacle to us being able to have a cohesive and coordinated response. But they also think about meaningful co-production, and I think there is really something in meaningful co-production that we need to focus on in GM. Interestingly, the Perinatal National Team have developed a Turning the Tables project looking at the core values and developing the core values of co-production, and I think there's a huge amount of work, and some of the answers really do lie in that co-production that we need to be progressing. But yeah, I mean, these are familiar themes. Services been designed for, well, not always the populations that they serve. Institutional racism is rife. There's lack of promotion of services in certain communities, cultural competence, poor availability of interpreters. We've got a Gujarati speaking patient on the ward at the moment. She's been here for 4 weeks. We've been able to secure an interpreter 3 times. Her English is okay, but 3 times in 4 weeks. And just imagine yourself in a hospital in Gujarati being in that position. Our written information isn't translated. Our websites are all in English. There's a lack of shared language beyond just the translation regarding symptomatology. There's poor representation of the population we serve amongst our staff groups, and the other themes as well, the lack of connectivity with the things that we have been thinking about today already. But we want to move on into the solutions. So next slide, please. So just thinking about what we are doing at a GMMH level, and this is at an organisational level, there is now an advancing equality strategy in place, and that's a strategic approach to advancing equality, which I think needs to be coordinated with all of the activity in GMMH and GM. There's also resource being developed at an organisational level, including investment in an equality, diversity and inclusivity team. There's partners to the National Advancing Mental Health Equality collaborations, because I think it's really important that we're learning from each other, and that these are key priorities in all of the business plans in 2023, 2024. For us in perinatal, we're lucky to have established links with CAHN, but again, I think this needs to be translated in something meaningful, and I'm really interested to hear about the maternity network and thinking about GMMH representation on that. I agree, BI is really important. We need to understand how we're capturing the data. Our early analysis looks like the number of Black women represented in community services is completely disproportionate to being represented on the mother and baby unit. So that hopefully will be a springboard to call to action why perhaps women from Black communities are presenting later and then needing admission. We also need to have representation and experts by experience and meaningful co-production. We have joined the Maternity Transformation Board Equality and Equitable Access Task Force, and we have identified in the perinatal and parent-infant GM-wide business case the need for resourced GM equitable access champions. But it does need resource. It does need to be properly funded for something meaningful to happen. Next slide, please. Sorry, I've got one more slide, I think. Yeah, so just thinking about some of the solutions, training, meaningful co-production, getting our resource directory embedded, who are the communities, how do we link in with them, how do we develop pathways and relationships and champions using BI, thinking about the community ambassadors that Faye you've talked about in your report, how can we have something parallel in our services in terms of our equality champions, developing networks so that we're doing this across maternity, physical health streams, cancer, mental health, learning from each other, and thinking about how we all campaign for additional resources and funding to have a meaningful response to this. And that's all from me, I'm hoping. Next slide, please, I think is just any questions. Yeah, thank you.
Thanks very much, Sarah. That's really insightful, and it's good to see some solutions even after the challenges. So at this point, I'm going to hand over to Laura Seaborn, who is the Chief Exec for the Maternal Mental Health Alliance. Over to you, Laura.
Thank you so much, Charles. If I could have the first slide, please. Oh, I don't see my slides. Never mind. Keep going. Here we are. So I'm going to talk a bit about inequities and social justice in relation to strategy and policy. So as I said, I'm the Chief Executive of the Maternal Mental Health Alliance. Am I echoing to others? Because I'm really echoing to me. Can you hear me okay?
You are echoing a little, Laura.
I don't know. I don't know what that's about. I've never had that before. Is it difficult?
We can cope with it. It's fine. You can carry on.
Really sorry. I have no idea. I'll try maybe to turn it down a bit. Is that better?
Yeah, it's fine. Yeah.
And we're just fixing it now. So you logged in twice.
How very odd.
Won't be long.
Anyway, is that better? There. Anyway, can you hear me okay?
Yes, we can.
Okay,
yes, we
brilliant.
Can.
Okay, sorry about that. So just to say, before I joined the Maternal Mental Health Alliance 2 years ago, my background is in homelessness and setting up a women's service across the North and Midlands for a charity with specialist attention for women who sell sex and experience sex exploitation, women in criminal justice, And so inequity and social injustice has been at the heart of my career, and it still is. Next slide, please. So our ambition at the Maternal Mental Health Alliance is to ensure that all women can access and receive high quality, compassionate care and support for their mental health during the perinatal period. And our objectives really are around raising awareness of perinatal mental health and using our collective influence to drive change in policy and practice and ensure lived experience is at the heart of our decision making. So we have a network of lived experience champions who are part of the Alliance. Can I have the next slide, please? So we're a membership organisation with over 125 members, and these span sort of grassroots community groups, national charities, royal colleges, and we're supported by clinical experts, policymakers, and our royal patron, the Princess of Wales. And really, the importance of being an alliance is that no one organisation can make the change that's needed. And I think we see that in the amazing sort of integrated map that Sarah just showed. You know, we've been operating as Alliance for over 11 years now, and what our role is about convening, facilitating, collaborating to try and lead a campaign for perinatal mental health and make sure that learning is amplified. Next slide, please. So what do we know about perinatal mental health is that it's common in that it's estimated that 27% of women, new and expectant mothers, will experience a perinatal mental health problem. And this is not just about, you know, the sort of fobbed off as baby blues. We know that 70% of women hide or underplay how they're feeling. So maternal mental health issues go unrecognised, undiagnosed and untreated. And this, we believe, is around the fear of judgment and stigma, fear of child removal, fear of sometimes immigration status, and that mistrust of how you're going to be cared for, and we'll come on to that. And we know that if left untreated, perinatal mental health can have a devastating impact on women, babies and families for years to come. But it is hugely treatable, and it is also could be a real story of hope. Next slide, please. The Embrace report has been mentioned already, and I think every year it's in the autumn these reports come out and we kind of steel ourselves. These are confidential inquiries into maternal deaths in the UK and Ireland. I think the importance of these reports cannot be underestimated. They honour those women who die in maternity before their time, and they're really fundamental to how we learn lessons so that we can save lives in the future. And ever since the 1990s, when these reports first singled out mental health as a cause of death, we have seen that discrimination, disadvantage and deprivation is directly connected to poor outcomes for women, babies and families. What we know is that Black women are 3.7 times more likely to die and Asian women 1.8 times more likely to die compared to white women. And that's a shocking statistic. We know that women from poorer economic backgrounds are twice as likely to die, and those facing severe and multiple disadvantage, so that could be domestic abuse, addiction, contact with criminal justice, have the poorest maternal outcomes, and these outcomes are getting worse. We also know that there's disparities for young mums, and the rate of teenage maternal suicide is increasing. It's heartbreaking that in the last report, all 10 of the mothers who died by suicide had their babies removed. So these reports really highlight that for those women most at risk of poor outcomes, these women were not listened to. And that's what these reports say. This led to inappropriate care, mistrust, and reluctance to seek further support. And this is never more than Black and Asian women. So in 2020, oh, sorry, next slide, please. In 2020, two amazing women, which we've heard about the 5 times more organisation already. Those two women were so outraged, and rightly so, by the statistic at that point, which was that Black women were 5 times more likely to die than white women in that maternity experience. they put out a petition to other Black mothers, and this went viral, just highlighting Black women's experience. Other charities joined, and we saw, you know, Birthrights and Motherhood Group. These charities have done astonishing work, inspiring challenge to such stark statistics. And I think it's important to highlight, and we've, you know, I think Faye talked a bit about this. It's about these grassroots, you know, Black-led women's organisations that have led this, inspired this because of Embrace, but it's been the voluntary community sector, those organisations who've led it. It took another year for the government to actually debate these statistics, and only because a very small number of MPs really pushed. You know, so it's vitally important. I think 5 times more found 3 key themes experienced by Black women in their petition and their sort of research that they sent out. First of all, it was attitudes, so women experiencing offensive and racially discriminatory language and their concerns being dismissed. Knowledge, so poor understanding about the anatomy and physiology of Black women, and poor understanding of the clinical presentation of conditions in babies of Black women. And assumptions, so racially based assumptions about things like pain tolerance, education level, and the relationship status of Black women. You know, and 5 times more talk about, you know, when they've tried to get this on the agenda, always being told, oh, it's the numbers are too small, oh, it's genetic, that kind of, you know, fobbed off. You know, we hear such horrific discrimination around women being told they're making a fuss or being ignored, or actually accused of being aggressive. So the Motherhood Group, led by Sandra Igwe, who we work with closely, the women they work with talked about self-policing their behaviour, even in childhood, aware of how they might be perceived by white society. And Birthrights, mentioned just then by Sarah, talk about how unsafe Black and brown women feel during their maternity care. And a Birmingham organisation that I recently went to their conference, Maternity Engagement Action, say how advocacy for Black women and their families can actually feel incredibly dangerous because it could lead to more punitive and punishing care. So with all of this, it's of no surprise that women often do not disclose poor mental health. So next slide, please. So for the maternal mental health, we looked at, you know, what are those strategic and policy levers? And I'm saying this as from outside of the health service. This is something Maternal Mental Health Alliance think about all the time. How do we reach all women? And I think about what Amanda Smith from Maternity Engagement Action said in a speech the other day about don't just talk about equity, do equity. And so we think about our sort of activities that we can do as an alliance with our members. We've recently been involved in the Amplifying Maternal Voices project, which is really working with grassroots Black-led women's organisations supporting perinatal mental health in Birmingham and Croydon. And the women, when we talk to the women there and those organisations, I mean, it really reflects what we've heard already about those organisations feeling they're always asked to contribute, and their sort of data and their wisdoms and their insights and their stories taken away, but never properly valued. So feeling like it's tokenistic engagement rather than having an actual seat at the table. And as Faye said, often, you know, religion and faith really not being acknowledged. And that, you know, what we need is, you know, to make sure there is a seat at the table, their voices are heard, and involved in service design, research design, you know, as said in, you know, Faye's call to action just now. So for us as an organisation, it's about, you know, making sure that what can we do is only ever be involved in events where there's diverse voices, seldom heard voices around the table. So, for example, some of those grassroots organisations making sure that they came to a round table we hosted with the Shadow Mental Health Minister, Abena Opamassar, recently in Westminster, taking over our Twitter account to really get those voices out. So making sure we're showing up, we're speaking out, doing everything we can. Next slide, please. Listening is just, you know, really going back to just listen to the reality of life for women. So at the moment we're doing a listening project with one of our members up in Newcastle, and it's around women who've experienced child removal, domestic abuse and addiction. We've done a listening project very recently with young mums across the 4 nations. You know, these are really important to make sure that we're then helping those women amplify their voices and giving them a place around that table. Next slide, please. Oh, sorry, just one back. Yeah. So I guess our role is to really try and influence and campaign politically and what we can do. And I was just looking back thinking, well, in 2021, the Black Maternity All-Party Parliamentary Group was set up to tackle racial disparities, chaired by Belle Ribeiro Addy, who is a fantastic campaigner. In 2022, the Maternity Disparities Task Force was set up to tackle disparities in maternity care. These are really important. I think just particularly the task force, I have a seat on that. It is yet to make an impact. There's not, you know, we're still not seeing the action, and this is reflected in April 2023 when the Women and Equalities Committee, chaired by Caroline Noakes MP, published a report recommending that there's a target set to end these disparities in maternal deaths, but this was refused by government. So there is so much for us to do to keep the pressure up and hold government, hold those responsible, hold those who are in positions of power to make a difference to account. You know, we know this, we know it year after year after year, these reports come out, but these statistics are just unacceptable and sort of stubbornly persistent. So our job is to shine a light and keep shining a light on what is holding back this action that was so desperately needed. Final slide, please. I just want to end really with a few of my reflections. So, you know, over the years, I've worked with women who experience a great deal of stigma and judgment. But I don't think I see any greater stigma and judgment imposed than those on motherhood and mothers. And particularly, obviously, what we're hearing today is that it's sort of systemic and structural racism within that for women. Never are women more exposed and scrutinised, yet poorly understood and unsupported than in motherhood. So, you know, then when we add another layer of those women who might say be refugees, asylum seekers, already traumatised, giving birth when English is not your first language, with no support systems or poverty or insecure housing. So we see trauma upon trauma. And for me, it's like we have to absolutely influence and advocate at that national political level. And that's our job as the Alliance, sort of trying to convene the membership to sort of have that powerful voice. But as individuals as well, you know, on average, someone during the maternity experience, on average, will have 16 contacts with a healthcare professional. There is so much power to do so much good in those, you know, in those moments. There's also power to do real harm in those moments. And I just sort of finished by Professor Prabha Chandra, who did a speech at the Royal College of Psychiatry last year, a couple of years ago, and which just always really touched me, saying my attitude and words have the power to either open somebody up. This is a mistake on my slide. My attitude and words have the power to either open somebody up or break the person. Thank you.
Laura, thanks a lot for those insightful presentation, and then also the data you've shared. And you absolutely spot on about holding the system to account. So for us at the Caribbean African Health Network, as we develop the all-party parliamentary group on Black health, we look forward to working closely with you. At this point in time, I'm going to hand over to Wendy Olaiwola, who is to talk about the national strategy and opportunities for improving maternal outcome. Wendy is a national maternity lead for EDI, for equality within NHS England. So over to you, Wendy.
Thank you very much, Charles. Can you hear me okay?
Yes, we can.
Yes, thank you very much. So I'm going to be sharing my slide, and thank you for inviting us today. I think it's been very, very insightful, to hear all the speakers before us, especially Faye, with that report that you've just shared with us. Thank you for all you do. Still tell me if you can see my slides. No, I'm just going to put it in slideshow. Can you see it's all okay now? I can't see anyone. I just need someone to tell me they're seeing the right slide.
We can see. Thank you, Wendy.
Fantastic. Thank you very much. So, right, I've been introduced. I just launched into the presentation. And I also do have some of my team on the call, I suppose, in case if there are any questions that you would like to ask. Hopefully, they'll be able to support, because I think I only have 10 or 15 minutes. And there's so much information we would like to share with you today. So let's start with this. What is the national driver that is driving us in this space in addressing health inequalities within the perinatal mental health? So the NHS long-term plan, perinatal mental health commitments, and it has its overarching ambition. And these are the overarching ambition, looking at the access, the duration, the therapies, as well as the partners. So the aim really is to increase access to specialists for all women, to specialist community perinatal mental health services to 66,000 women per year. And also there's been an increase from 12 months to 24 months, extending that community services up until 24 months after birth. And most importantly, increasing access to those psychological therapies within the PMH services, which not just focusing on the mother and baby, but also the family, using those family interventions, and extending that support to partners as well. The mental health, and also signposting the partners, as required. And in addition to all that is the establishment of maternal mental health services for all women with mental health needs. Needs arise from trauma or loss in the maternity context. So in addition to that as well is the latest national data, which shows that just over 54,000 women and birthing people were reported to have accessed specialist community perinatal mental health. And in the last 12 months, towards the end of December 2023, and that is an increase of 33% from 41,000 plus 2 years previously, and 79% from just over 30,000 in March of 2020. So as of February this year, there were 34 fully operational maternal mental health services in operation, which obviously include and combines the maternity, reproductive health, and psychological therapy for women experiencing mental health difficulties related to the maternity care. So, in terms of addressing inequalities, which is an essential element of expanding these services, there are 3 key equalities area for specialist perinatal mental health services, and these are women and birthing people from ethnic minority backgrounds, young mothers up to 25 years of age, women facing multiple adversity, including domestic violence and deprivation. There are quite good resources around for people to actually tap into in terms of information, case studies. If you really want more, there are quite a lot of those information on how these are being addressed and being supported on our future NHS collaboration platforms. However, you will need an NHS email to address those information, and we can also support you to address those information. So in terms of asset, outcome, and experiences, what do we know? What are the facts that we know? And many of these, the speaker just before me has actually given a bit of context and reminding us of what those information that we already know that are out there. We do know that women from ethnic minorities have poorer outcomes and experiences of care. That's a fact. We know that. We have evidence of that. And we also know that they face greater barriers, challenges in accessing specialist perinatal perinatal mental health services. And we also do know the Embrace report as well. And the latest one, I believe that was Laura that spoke before me. You know, I've already taken us through all this, so I'm not really going to dwell on this. But the most recent, you know, latest from 5 times more to 4 times more is now 3.8 times more likely for Black women to die in pregnancy. I mean, we have seen that, you know, data dropping, which is a good news, but there's still so much to be done. We're still uncomfortable with the current data that we're working with. We know the Asian women are now 1.8 times more likely, and those are human beings. Those are women, those are beings behind this data. So we are uncomfortable about it. We know that women from ethnic minority also experienced, you know, disruption in accessing perinatal mental health, especially during pandemic. And this is particularly in relation to digital barriers of accessing remote delivery of care. So we have all that knowledge, we have all that information. So what are the issues? What are the things that we really then now need to be doing? And in addition to what we know, there was a national study which was published in 2020 using the 2017 data, found out that access to perinatal, the mental health services or access to perinatal mental health services during this period varies significantly between women from different ethnic groups. That's also something that we are very much aware of. We have those data to inform us of that. And also access to community mental health services. You know, the report also suggested that access to community mental health services should be facilitated for Black African women, Asian and white other women during the perinatal period, and which may reduce rates of involuntary hospital admissions for these groups. So the pattern of engagement with community services for women from this ethnicity indicates that access appears to be a problem rather than utilization. So yes, we know there is an issue with access as opposed to engagement. So that is very much a known fact. So the chart from the research outlined in the previous slides, the orange bars highlight the groups which had lower access to specialist perinatal mental health services than white British women, which is in dark blue bar. The lighter blue bars shows the groups which had similar rates to white British women, and this includes Black Caribbean women. Mixed white and Black Caribbean women, shown by the green bar, had statistically higher access. And it is important to note that even though this data is from 2017, this still aligns with recent service access data that is still available. So this slide highlights how services can understand and improve access to the services for ethnic minority women. So again, it's about understanding the local population, the service providers, the system should understand population demographics. For example, using the public health England fingertips tool, the SHAPE tool, and the health equality assessment tool. So we have all these resources for service providers, all the systems to understand the local population demographics, and also to compare this to the women who are accessing their services. There are a lot looking at the percentage of the caseload by ethnicity, looking at the percentage of the age and deprivation, and most importantly, reaching out to ethnic minorities that are underrepresented in their services. And these are the list of things that they need to consider when going through that. So in addition to that, to all this, the National NHS England Perinatal Mental Health team is also supporting the system in these areas in a number of ways. And this includes, and they have done quite a lot of things, delivering best practice webinars. The last one that was done on equalities webinar was last month. They've commissioned a perinatal mental health workforce census, which looked at the breakdown of the workforce ethnicity compared to patient ethnicity, guidance and recommendations on how to improve ethnicity data following a survey of more than 160 staff working in perinatal mental health services. Case studies on understanding and responding to local populations, principle of co-production, co-design, with diverse communities, developed with members of the National Perinatal Mental Health Co-Production Group. So my slides really look at, the recent framework that was, published and launched in October 23, and that is first of its ever, anti-racism framework, and it is the patient and care race equality framework, and this is for all the NHS mental health trust and mental health service providers to embed into their services to improve experiences of care for racialized and ethnically and culturally diverse communities. So what does this framework stand for? It requires organizations to act on leadership and governance. It requires them to look at cultural competencies. And I think Faye actually alluded that in terms of the importance of cultural competency training for all our staff, feedback mechanisms. This mandatory framework also will support trust and providers, including perinatal mental health services, on their journeys to becoming actively anti-racist organizations by ensuring that they are responsible for co-producing and implementing concrete actions to reduce racial inequalities within the services. This will also become part of the Care Quality Commission inspections. So mental health providers are really supported to look at take practical steps to implement the framework and positive practice from the pilot sites which is available. And Greater Manchester Mental Health Trust was one of the 4 pilot areas. So what are the good practice guidance? So far, we have looked at specialist community perinatal mental health services for women with moderate to severe mental health needs. However, it is important that all women should have access to mental health and well-being support from maternity and neonatal services. So in August 2021, NHSE, as in NHS England, published the 3rd guide for commissioners and staff involved in maternity and neonatal care. So this describes the underpinning principles of and good practice for supporting good mental health and psychological well-being in maternity and neonatal settings. It also considers the role of specialist maternal mental health services in supporting this function. It highlights that psychologically informed care should be consistently available, accessible, respectful, sensitive, and equitable to all, and consider the cultural and personal circumstances of people from diverse communities. So this slide shows the new services that are there to support women from moderate to severe mental health needs arising from the birth experience, and also to fill a gap that was not being met by other mental health services. Due to time, I won't go further into that. But the last point is, and it's so good to identify that and to flag that 34 mental health services are now live with services in each integrated care system area in England due to be operational by the end of 2024. Many of you may have seen this, especially for those that are working in maternity and neonatal services or systems. The 3-year delivery plan, which was published last year, there is a bit about, it was published last year of March 2023, and set out a number of initiatives and ambitions in that. But what I just wanted to narrow down is the part of equity and the mental health that was published in there. So equity and equality plans set out the actions in this plan required to reduce inequalities in experience and outcomes for women and their families. Equity and equality guidance, for many of you that are familiar with the local maternity system, that was again published a couple of years ago, and set out interventions to improve equity for mothers and babies, raise equality for staff, including implementing maternal mental health services with a focus on access by ethnicity and deprivation. So last year, December 2023, again, NHS England published guidance for the GP, general practitioners, to improve the quality of the 6 to 8 week maternal postnatal consultation. If you haven't seen that, I'm happy to, again, send a link to that. The guidance provided detailed information about perinatal mental health offering resources, guidance on management, and onward referral. The guidance also outlined resources and strategies to implement locally that take into consideration equity in access, experience, and outcomes for specific groups, highlighting some of key factors for consideration when working with women most at risk of health inequalities. So in development of that toolkit to support the system with postnatal improvement initiatives, this toolkit highlights the importance of system working, ensuring all services and organizations work together to improve outcomes for women, babies, and families in the postnatal period and up to 12 months after birth. It will also focus on the system on joined-up care that is tailored to individual needs while supporting leaders to ensure resources are targeted to meet the needs of the most vulnerable women and the local communities. So due to time, we're just going to stop there, but happy to share any information. So thank you very much, CAHN, for inviting us.
Thanks very much, Wendy. That was really insightful, and lots of claps, lots of, thumbs up in there. So please stay on. So at this point in time, I haven't heard from various speakers. We're going to move on to the Chief Exec for the NHS Greater Manchester, or our Integrated Care Board. And we're really delighted that Mark is here, as well as with Mandy Philbin, who is the Chief Nursing Officer and also the interim Deputy Chief Exec for the ICB. So over to you, Mark and Mandy.
Thank you, Charles, and it's a complete pleasure to be here. And I really listened very, very carefully to all those fantastic presentations. And this work really blends so well, and so well with the work of our Integrated Care Board and our ambition for reducing health inequality across Greater Manchester. But I'm going to ask Mandy, who is not only my deputy and our chief nurse, but our lead on maternity services, to talk in detail about what we're up to. So I'll hand over to Mandy, but then both of us will be around if there's any questions, no doubt. Mandy, over to you.
Thanks, Mark. Thank you. Thanks, Charles, and thank you, Faye. You always feel humbled, don't you, when you're on such a call with such eminent speakers. And I think if it gives you an emotional reaction to what you're listening to, it's really powerful. And I think we need to thank Sam for that, because that were a brilliant voice that she put forward. What it concerns into is that she described having 7 children and same problems still coming to the forefront. So it's really good that Faye and others have been able to put this report forward to really drive and address some changes. We've heard some powerful work that's already undertaken. And I think really from an ICB perspective, this is allowing us the chance to connect and draw this together. A lot of times we talk in isolation. So we talk about mental health issues and we talk about maternity issues in children and young people and safeguarding. But it's not often that we ever really connect them. And from an ICB perspective, I think this is the opportunity, and the opportunity of bringing back local care to patients in communities and their families, as well as bringing them hospitals into that position, will be really powerful. And I welcome the report, and it's been, as I said, very humble to listen to people's not just data but their experiences and how powerful it is. As an ICB, it's not just important for us to connect care, but it's also to recognise priority of care. Some of you may and may not have seen that the Integrated Care Board is very much focused on health inequalities, this being one of them drivers behind it. To do that, we need to do financial support in service provisions, and we need to think how we recommission services, because we've not got maternity services right across GM. I know we're talking about this cohort at the moment, but generally the feelings is that we haven't got high quality, the experiences are poor. It's representing everything that you've just described. What we've got with ourselves, though, is very much a much bigger impact for this cohort of patients and families. And it's important that we start to address that. From a local maternity neonatal service, we've got an equality plan that's already being shared, and the providers are working towards that. And that's actually assessed. It's coming up again in a couple of weeks' time to actually review where we are against that. Very much around what Faye described around lack of education and understanding, which plays into who are we recruiting and how we're getting that equal voice. We really need to focus on involvement, and that's been really powerful today, that we're professional in our own right, but we're not the experts. We need to recognise that, and the ICB will leverage that for us as well, very much bringing that voice to the forefront and helping shape and co-produce services, not just doing more at the same. And I think that's important. Recognising that we need representation of that workforce and working with regional teams and national in that professional forefront to actually say, who have we got to support and understand this level of care? And them numbers, while they're improving, they're definitely not where we need them to be. So an ICB's objectives, I'm hoping I've portrayed here, is very much around bringing care back into community to understand population needs, very much around listening to that voice and actively using that voice, not just saying, thank you very much, that's your report, I'm going to put it on shelf and I've done. We've got to take this and really harness it. I can't have Samantha sat here in 2 years' time, if she has another baby, depends how she's feeling, but very much going, I've just experienced the same again, despite everybody on this call committing to make improvements. Now, the journey will be hard. There's a lot of cultural issues, a lot of stigma, like everybody's described, that we have to break through. The ICB has to set the culture, our organisations across health and social care, to really drive changes and not just be the voice of these 154 people on this call, but very much be the voice of our community and patients. So I will pause there. I don't know if Mark wants to come back really to reiterate any further points, or if not, I'll hand over back over to Charles, but thank you.
I'm very happy to hand over to Charles, but I just agree with everything Mandy's just said. Obviously, we've got lots of work to do in NHS Greater Manchester, and lots of reform to undertake in this area, because we have some really powerful objectives linked directly to the sort of stories we've just heard. So thank you.
Brilliant. Thanks, Mark. Thanks, Mandy. I think we've got a question in the chat about what will your actions be to meet the objectives that you've set. So I think that's hot off the press question.
Do you want me to come back on that first? Would that be okay, Mark? I hope you don't mind. So some
no, you go first. Come.
Thank you. One of the first objectives is really securing funding. I'm sure people are very aware of the financial viability that we all face across NHS England. So there is already funding that's been enacted and secured. This is very much around understanding the education aspect and making sure we've got that peer service in place. So there's been already investment in rainbow peer services. There's some video development, which is around bringing that voice to change that culture that we need to do. And very much around, as I mentioned or alluded to, maternity services need reviewing across GM. And we're just embarking on that conversation in this next few weeks, but very much looking at changing, bringing back into community around what that is. And that this voice is front and centre in there. The outcomes are not what we want. We can't keep doing more of the same.
Thanks, Mandy. So we got meant to me to run in. Please make sure you give us some comments and some feedback. And happy to take a couple more questions. So give us extra 5-10 minutes of your time and we will wrap up shortly. So any further questions for any of our speakers? Faye, do you have any private questions sent over to you?
I think Sakinat's been rounding them up from the chat box. So if there's anything in the chat box, otherwise we'll do next steps and we can finish.
Okay, Sakina, any questions for any of our speakers? So there's a question here, Mandy and Mark. Is there an opportunity to do a future study following this study that includes dads?
Sorry, Charles, say that again. Sorry.
So there's a question asking if there's any opportunity to do a future study that includes fathers as well and their experience.
Brilliant idea. Brilliant. Yeah.
Thanks. So another question, how do we increase representation in maternity services and health visiting? So Mandy, do you want to take that, or Wendy or Laura?
If I can pick first part up, particularly this comes around nursing recruitment, and I will speak in that arena rather than thinking about voluntary sector, which I know the people can present into that. There's been a lot of work done around international recruitment, mainly because of shortages in nursing, but actually there has been a good increase in midwifery services, but it's still not where we need it, and it's not represented in our entire community. I think for GM, some focus that we need to do is really targeted intervention and work with our universities to make sure that people are tracked well, managed well, and can finish their training, because we need to be respectful of that scenario that they're facing. There is also making sure that that voice is there represented through voluntary sector. So again, describing that journey that you're saying it's missing, to be that voice if people can't speak up and describe what they want. So there's a lot of work to be done. There's work already underway, but a lot more work. But I'll pass it on to another colleague on call.
Yeah, I'm happy to follow that good answer, Mandy. I thought that was really, in addition to that, we know that we cannot sustain international recruitment. So again, can you hear me okay?
Yes, we can.
Okay, so it's really about encouraging our community to come on to midwifery. You know, midwifery is a lovely course. I'm a midwife of almost 30 years experienced, and I can't do any other job other than being a midwife. So we just need our communities come and join us. Let our population, let our workforce reflect our population and the services that we provide. So it is important to start putting those good words out about midwifery, about health visiting. If you want to see someone that looks like you, caring for you, then you need to get on and come and join the profession. I think that's what I'm just going to put out there today.
Thanks, Wendy. And I think, Mark, there's a question here in terms of the mental health support, considering the savings that the ICB needs to make, would it be worth investing in existing services and then, you know, providing that holistic support?
So, yeah, you know, it's a common knowledge that this ICB, we're not the only one in the country, has some financial challenges, but I'm really keen to meet those in a way that doesn't impact on our core services, and indeed in particular doesn't impact on our mental health work. We have a mental health standard, investment standard to fulfill, which we are absolutely committed to fill. I'd love to invest even more in mental health services, because I think Greater Manchester, actually compared to the rest of the country, probably underinvests in mental health services. And we've got lots of work to do to transform those services right across Greater Manchester, both in the community and in the hospital service. And clearly the sort of conversations we've been having today, I'd see as very much part of input into that process and that work and that thinking. But, you know, we are committed to mental health investment standard, committing to invest more in mental health. That's absolutely what we intend to do.
Thanks, Mark. I'm just wondering, Sarah Cook, yeah, and then Laura, any final thoughts from yourself before I do the closing slide?
Yeah, thanks, Charles. I think just thank you to all of the speakers, and particularly those that have shared their own experiences. It's always so humbling when people speak so personally and from the heart, and it gets the message across in a way that reports and data and graphs just can't do. So thank you for that. And just to kind of say that, you know, in terms of voluntary sector activity, we're out there doing loads of stuff across communities in Greater Manchester. There's always more that we could do. We all know that, but I think that, you know, the really positive thing that we've got in Greater Manchester is that whole system approach to trying to, you know, think about this across the perinatal and parent and mental health systems. We know that there's not as much investment across the whole system as there could be, and, you know, people are hopefully working on that. And there is definitely that commitment to work in a very kind of partnership-led way, so that voluntary sector activity can be hopefully broadened out. You know, we've got some a good established offer through Home Start. We've got our Dad Matters work, but we know that there's more that we can do as a voluntary sector across GM to really kind of, you know, develop some of this work and really think about how to reduce some of those health inequalities. So this report, I think, has been an opportunity to really just take a moment to think about what we can do, and it's given us some really clear recommendations for future activity. We have been able to secure a little bit of funding for CAHN to put some of those recommendations into action. So that will start to happen over the next 12 months or so. So I do hope that if we do revisit this and in terms of research in a couple of years, I do hope that we will see some real progress across GM, and that's certainly the intent from across the system.
Thanks, Sarah. Laura, and then we go to Sarah Jones.
Yeah, I mean, just to say, I'm going to say that as a with the Maternal Mental Health Alliance nationally, we really hear about the whole system approach in Manchester, and what you're doing is phenomenal compared to many other areas. It really is, and we see that a lot, and we hear about it. I totally appreciate it's really refreshing. The Integrated Care Board going, yes, we have so much more to do, and we all do. But just I just wanted to reflect that, and I think it's really hard for a big sort of beast of an infrastructure like the health service to commission, you know, grassroots voluntary sector community organisations. It's difficult to do that, but we absolutely rely on this diverse, thriving sector that are kind of different in different places, and rightly so, because that's the beauty of it. But I think I love the sort of ambition that I'm hearing to really do that, and to do that well, because these organisations are the ambitious solutions to health inequalities, to tackling it. So yeah, it's been absolutely brilliant being part of this today, and thank you.
Thank you, Laura. Dr. Sarah Jones.
Thanks so much, Laura, and that's so lovely to hear. We absolutely are committed to a very ambitious model, but I just really, it's really helpful to hear Mark's comments about funding being prioritised for this programme and for this area. And thank you to Faye and Charles for inviting us today and bringing us together. And hopefully we can start turning some of the energy in this forum into action. So that's all from me. Thank you very much.
Thank you very much, Sarah. So I'm going to have the last slide. Whilst the slide comes up, I just want to say massive thanks to all our speakers. Thanks to Sarah Cook. You've been there right from the outset, but then also support from Sarah Jones and, you know, the other Sarah, and then, you know, Dr. Lee and many others. And also really reassuring, you know, Laura, for you to come from a national level, as well as Wendy, to, you know, add your voice to what we're doing in Greater Manchester. And for ICB Chief Exec and, you know, Mandy, you know, massive thanks for giving your time. You could have delegated anyone, but you wanted to be here, hear their experiences. And then for the mothers, birthing mothers, the women that have given their experiences in the report, but then the two brave ones that have shared it this afternoon as well, Samantha and Treasure, massive thanks. As you would have heard, you know, the ICB has made some investment available for us to pilot something over 12 months. And we're excited about it because it's a foot through the door. It's a start in itself. And you know, hopefully we can evaluate the impact. So I'm going to have the last slide to give a quick overview and then how people can get involved. So the report, the full report has been shared in the chat box, and you would see the various recommendations. But there are a couple of things we've picked up on out based on the resource available. So first and foremost, we want to come up with a directory of services that are available. In the chat earlier on, people were sharing what was happening in Wigan, in Bury, and other places. And so want to get an online resource. So, you know, you had Samantha, you had Treasure, where people can turn to for support is really important. And then the other thing we want to do is to co-produce a culturally appropriate brochure and a leaflet, you know, that stakeholders can engage with. We're going to try and get some peer support going, and because of resource constraints, it will be, you know, a WhatsApp group, it will be a Facebook group to support birthing mothers. And then for our system partners, we want to be able to offer some cultural competency training, you know, to the perinatal and infant mental health teams across Greater Manchester. But then also we know there are pockets of brilliant work happening. And, you know, thanks Mandy for agreeing to involve fathers as well. So we're going to collect a bank of online resources that can support, you know, various teams as well. And then we're delighted that we can pilot a hub that has 2 drop-in sessions on a weekly basis. And it will add to the existing and the emerging family hubs that are being run. But then also building on the Core 20 Plus community connector model, the trainer models, we're hoping to have 12 ambassadors trained that will do some outreach into mainstream providers and support some of the work. With our Core 20 Plus community connector program, we've had those, you know, community connectors working at primary care level and making a real difference. And then we will keep in touch, trying to get some quarterly communication about how the program is going and some of the impact stories. So massive thanks once again. A lot more coming up, but I'll hand over to Faye for final words. But thanks so much for your time this afternoon.
Yeah, just to echo what Charles has said, thank you so much to everybody for being on the call. It's been really good to hear just some of the energy and the passion to be able to make a difference to what we know is a problem within Greater Manchester for Black women and for other women as well, from other diverse cultures. So thank you to everybody for all your contributions. Please keep in touch with us. We really want to keep hearing from you, any solutions, anything that are going on across Greater Manchester, that you can really help to give our Black women a really good experience. So thank you to everybody again, and keep a lookout for what's happening next. Thank you.